Hi guys, and welcome to chapter 8, and this will be on the appendicular skeleton. So we went over the axial skeleton, introduction to bone tissue in chapters 6 and 7. Chapter 8 is the appendicular skeleton. So these will be all of your limbs, and then chapter 9 will be on joints. Use this PowerPoint to study for your lab exam as well, and I will try to go through some of the specifics of the bone markings that you guys should know. So in the appendicular skeleton, we have the pectoral girdle and the pelvic girdle. The pectoral girdle attaches the upper limbs to the trunk, and the pelvic girdle attaches the lower limbs to the trunk. The upper and lower limbs differ in function, obviously, but they share the same structural plan, as we'll see. So your pectoral girdle, first of all, consists of your clavicle and scapula. The pectoral girdles do not quite encircle the body completely, so the medial end of each clavicle articulates with your manubrium and the first rib, and laterally your clavicle joins with your scapula, and the scapulae do not join each other or the axial skeleton. The pectoral girdle provides attachment for many muscles that move the upper limb, and the girdle is very light and the upper limbs are mobile. The mobility of the pectoral girdle, only the clavicle articulates with the axial skeleton. And sometimes that's a good test question. What's the only part of the appendicular skeleton that articulates or touches the axial skeleton? And that is the clavicle. The scapula can move freely, and the socket of your shoulder joint, called the glenoid cavity, is shallow, which is very good for flexibility. You can move your shoulders very well, but it's not very stable. And we'll talk about that when we get to joints. So this is a great animation of the rotating shoulder. Download the PowerPoint to watch that. And here's the pectoral girdle. So you can see the clavicle joining with the acromioclavicular joint at the scapula. The clavicles extend horizontally. The sternal end articulates with your manubrium, and the acromial end articulates with the scapula, the acromion process of the scapula. So here's a look at your clavicle. You need to know the difference between the acromial end, which is a little more curved, and the sternal medial end, which is more straight. And here is an inferior view. The clavicles provide attachment for muscles. They hold the scapula and arms laterally, and they also transmit compression forces from the upper limbs to the axial skeleton. So because you have a lot of pressure going through your clavicles, if you fall on your arms, that pressure usually goes through your clavicles, and a fall usually can cause a common fracture in your clavicle. The clavicles are one of the most common fracture points in the body because there's so much pressure put on them and through them when you fall on your arms. The scapula lie on the dorsal or posterior surface of the rib cage. They're located between ribs 2 and 7. They have 3 borders: superior, medial, and lateral, and they also have 3 angles. So here's a great review of the anatomy of the scapula, which you guys should spend a lot of time reviewing. All of these surface structures on the scapula are fair game for the lab exam. Here is the medial border. The lateral border will be the area where the glenoid cavity is, because that's where your arm will come out, and your arm is more lateral. The acromion is the pointed edge that you feel if you touch your shoulders. You're touching your acromion. Here's the coracoid process. They both provide attachments for ligaments that surround your shoulder joint. The superior border, and then we have the superior angle and the inferior angle. The subscapular fossa is the depression on the anterior side of the scapula that will hold the subscapular muscle. And here's the posterior side of the scapula. You can see the superior and inferior angle, medial and lateral border. You see the spine of the scapula, and you can feel that spine and how it ends in the acromion at the top, and the coracoid process on the anterior side. Here's the scapula, and looking at the scapula from the lateral view. Sorry for that brief introduction from my daughter. So here's a look at the scapula and the shoulder joint as shown in a radiograph or an x-ray. Then we get to the upper limb. There are 30 bones that form each limb, and they're grouped into 3 sets, whether it's the arm, the forearm, or the hand. The arm is the region of the upper limb between the shoulder and the elbow, and this is where the humerus is. The humerus is the only bone of the upper limb. It's the longest and strongest bone of the upper limb, and articulates or touches. Whenever you see the word articulate, that means touch. with a scapula at the shoulder, and it also articulates with the radius and ulna at the elbow. There's many structures of the humerus that provide sites for muscle attachment, and other structures of the humerus provide articulation sites for other bones. So here we have the humerus and some important things that are on your lab list. The head of the humerus, the greater and lesser tubercle are bumps on the anterior side of the humerus. The intertubercular sulcus, it serves as an attachment point for your biceps tendon. The deltoid tuberosity is a slight raised bump on the humerus where your deltoid muscle will attach. And then at the bottom, we have a lot going on with the humerus. And I just made your lab exam, and you do need to know well these structures at the base of the humerus. I think there's 2 or 3 questions labeling some of these structures. There's the capitulum, which kind of looks like a bald head, and then a trochlea, which looks like an hourglass structure. And then above the capitulum and trochlea, we have different fossas. The radial fossa will be where the head of the radius sits when you bend your elbow. And the coronoid fossa is where the coronoid process of your ulna sits when you bend your elbow. Your medial epicondyle juts out on the medial side or inner side of your elbow. So this is the distal part of the humerus, but the anterior side. So from an anterior view. From a posterior view, we just have one fossa, the Olecranon fossa. And this is where your ulna, the Olecranon process of your ulna, will sit when you bend your elbow. And then on each side of the distal end, we have epicondyles, which are small bumps, the medial and lateral epicondyle. If you're confused with which side is medial and lateral, the head of the humerus is more medial because it's closer to the midline, it's closer to the inside of the body. And the medial epicondyle is also on the medial side of the humerus, which will be where your head is. You also have the surgical neck and the anatomical neck, which surrounds the head of the humerus. So this is a great picture showing these structures and how everything fits together at the elbow joint. So here's the capitulum, that kind of bald-headed kind of structure, looks like a marble. Here's the trochlea. Above the trochlea is the coronoid fossa. And it's not labeled, but above the capitulum is the radial fossa because the head of the radius will sit in there when your elbow bends. Here's your ulna, and the coronoid process of the ulna will fit into that coronoid fossa when your elbow bends. Here's some great looks at the radius and ulna. The head of the radius looks like the top of a golf tee. The radial tuberosity is a slight raised bump. And then here is the ulna. Here's a posterior look at the elbow. The Olecranon process of the ulna will fit into the Olecranon fossa on the humerus. You can see the medial and lateral epicondyles, the head, neck of the radius, and then the long ulna. So that is what makes up the elbow and how everything moves together as you bend your arms. The forearm then consists of your radius and ulna. The proximal ends articulate with the humerus, and the distal ends articulate with your carpals, which are your wrist bones. Here's a great animation of the rotating elbow. So the forearm, the radius and ulna articulate with each other at the proximal and distal radial ulnar joints. And there's an interosseous membrane, which is kind of connective tissue that connects the radius and ulna together. And in anatomical position, this is very important to remember, the radius is lateral and the ulna is medial. So the ulna is the main bone responsible for forming the elbow joint with your humerus. It's a hinge joint, and it allows the forearm to bend on the arm. The distal end is separated from the carpals by fibrocartilage, and your carpals are your wrist bones. And the ulna plays little to no role in your hand movement. It just works in that elbow joint. These are the major landmarks of the ulna, which you should be familiar with for lab. And these are listing the landmarks of the ulna. So the olecranon or Olecranon process is the part that sticks up from the ulna. Inside the olecranon, we have a smooth curved surface, which is called the trochlear notch. And that's the part that will articulate with the trochlea on the humerus. The coronoid process is a little like kind of piece that juts out from the trochlear notch. Here's your ulna. And at the distal end of the ulna, we have the head of the ulna. And then the styloid process is this little piece. If you can see it here, that's kind of sticking out right there. That's the styloid process. And then on the radius, I'm going to go through a couple of structures here. There's a styloid process that sticks out on the base of the radius. And then there's a lot going on at the head of the radius. the neck, and then the radial tuberosity is the bump that sticks out on the radius. For your lab exam, you do need to know how to spell these as well. So just practice writing out the names to learn how they're spelled. Here's the Olecranon, the ulna. You can see better here the styloid process of the ulna, and the head of the ulna, the styloid process of the radius, and then the head of the radius looks like that golf tee that you put a golf ball on, and the neck of the radius. Here's a great zoomed in look. Here's the Olecranon. The trochlear notch is the inner smooth curved part, and the coronoid process. There's a little radial notch on the ulna where the head of the radius will sit. And here's a look at the distal ends of the radius and ulna, kind of looking at it almost an inferior view. So we have the radial styloid process, the ulnar styloid process, and the head of the ulna. The radius then, the superior surface of the head of the radius articulates with the capitulum on your humerus, and medially the head of the radius articulates with the radial notch of the ulna. It contributes heavily to the wrist joint because the distal part of the radius articulates or touches your carpal bones or your wrist bones. So when the radius moves, your hand will move with it. Here are the major landmarks on the radius. This is one of the hardest lab exams because there's so much to learn of the skeletal system. So please start studying now. And here's just another look. I've showed this picture before, but use these pictures to study the different landmarks on the radius and the ulna and how everything connects to the humerus. The hand then includes your wrist bones, which are your carpals, the bones in your palm, which are the metacarpals, and the bones in your fingers, which are called the phalanges. The carpus forms the true wrist. This is the proximal region of the hand, and the gliding movements occur between the carpal or the wrist bones. And the carpus is composed of 8 marble-sized bones. The carpal bones are arranged in 2 rows, proximal and distal rows. And if we go lateral to medial, the scaphoid is the most lateral. So the scaphoid is the closest to the thumb. And the scaphoid might be one that's labeled on a lab exam. Then we get through the proximal row of bones, lateral to medial, and the distal row of bones, lateral to medial. A mnemonic to help remember these carpals that start with each letter: Sally, scaphoid; left, lunate; the, triquetrum; party, pisiform. The next row, to, trapezium; take, trapezoid; carmen, capitate; home, hamate. So that's a little mnemonic device to help you remember the names of those carpal bones. And here's how they look. So the scaphoid, we start in, so this is the proximal row where my cursor is, and then the distal row is here. You can see here, so this is the entire scaphoid bone. I'm just going to kind of color it. So there's the scaphoid bone, and then we go over scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. So this is the proximal row and the distal row, and the one that I labeled on the lab exam is the scaphoid. So that'll help you a little bit there. This is a posterior view of the right hand and seeing where the carpal bones lie, and here's the scaphoid bone from a posterior view. Remember, always, always, always remember that the radius, and I'm going to go back to this page, the radius always lies laterally, so it'll line up with your thumb in anatomical position, and your ulna will be on the pinky side in anatomical position. The metacarpus then are the metacarpal bones that radiate from the wrist, and the metacarpal bones form the palm, and they're numbered with Roman numerals 1 to 5, beginning with the pollex, which is another word for thumb. So the pollex is number 1, and then so forth. And I'll show you what these look like. The phalanges then are also numbered 1 through 5, beginning with the pollex, which is another word for thumb. Except for the thumb, each phalange has 3 phalanges because your fingers can bend in different parts: proximal, middle, and distal, except for your thumb, which just has a proximal and distal. I'm hoping we show a picture of a hand, but I don't. You might have to use some of the lab resources for that to see the different phalanges and metacarpals on the hand. So here is a review, the bones of the upper limb. You guys can review this here. And I still am looking for a good hand figure, but I think there's a good hand figure in your lab book and some of the other materials that are on Canvas. But here are the carpal bones in the wrist. And then here are the metacarpal bones. So the metacarpal bones form the palm of the wrist, and they're labeled Roman numerals 1, 2, 3, 4, and this is hard to write, really small, and 5. So those are the metacarpal bones. And then the phalanges are your digits or your fingers. You have proximal and distal phalanges. So the distal phalanges are the tips, distal, 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 distal for every finger. And then the proximal phalanges are the ones that are attached to the metacarpals. The thumb just has a proximal and distal phalange, but you can see here this row of phalanges. Your 4 other fingers can bend in 3 spots. You can see that here when you bend. So there's a middle phalange in your fingers, but there's just a proximal and distal in your thumb because that can only bend in 2 spots. So the pelvic girdle then attaches the lower limbs to the spine. It supports visceral organs. It attaches to the axial skeleton by strong ligaments. The lower limbs have less freedom of movement and are more stable than the arm. The pelvic girdle consists of paired hip bones, which are also called your coxal bones or pelvic bone, and the sacrum. And your coxal bones unite in the front anteriorly with each other and unite in the back posteriorly with the sacrum. So here's a rotating hip animation. The pelvic girdle consists of 3 separate bones in childhood, and they eventually fuse together and retain separate names to the regions of the coxal bones. So here are the 3 separate bones of the pelvic girdle, which we'll talk about. And the acetabulum is the deep hemispherical socket on the lateral pelvic surface. This will receive the ball-shaped head of the femur at the hip joint. The ilium then is the large flaring bone. It forms the superior region of the coxal bone. It's the site of many muscles attachment and articulates with the sacrum to form the sacroiliac joint. And I'll show you pictures of this. The ischium forms the posterior inferior region. Anteriorly, it joins the pubis. And the ischial tuberosities are the strongest parts of the hip bone. And the ischial tuberosities are what you're all sitting on right now. The butt bone is your ischial tuberosity. Then the pubis forms the anterior region of the coxal bone. It's horizontally in anatomical position. And the pubic symphysis is an area of fibrocartilage that joins the 2 pubic bones together. During pregnancy, the pubic symphysis will soften to allow the pelvis and pubic bones to separate to allow more space for the delivery of a baby. And the pubic arch is inferior to the pubic symphysis. The angle of the pubic arch, whether it's very wide for a female or narrow for a male, helps to distinguish the pelvic male and females. So here's a great animation of the rotating pelvis. Please watch these. They'll be a huge help for your lab exam too. So here are the bones of the pelvic girdle. And we talked about how there's 3 bones that make up the pelvis. The ilium is the large bone on the top. You can see them both here. There's an iliac fossa, which is a depression in the ilium. The pubis makes up the front bone of the pelvis, and the pubis bones are joined together at this area of fibrocartilage called the pubic symphysis. And you can see the pubic arch is the angle below them. And then the ischium is the bone on the inferior posterior side. So there's the ischium. You can see other labeling structures here that you will need to know: the anterior inferior iliac spine, the anterior superior iliac spine, the iliac crest. There's other things that we'll show better pictures of, but I think that's all I want to focus on now. And this is a great picture showing the 3 bones of the pelvic girdle, how they all come together and fuse in this acetabulum region, which is the location where the head of the femur will sit in the ball and socket joint. So here is the ilium bone, the upper half of the pelvic girdle. Here's the ischium bone, the bottom back half. Here's the ischial tuberosity, which is what you're sitting on. Here's the pubis that makes the anterior lower half of that pelvic bone. Here is the greater sciatic notch. It looks like half of a heart shape. Here is the ischial spine, which the ischial spine might be one that is identified on a lab exam, as well as the greater sciatic notch. I'm trying to give you guys some clues, a little bit of help with that lab exam. And then other structures of the ilium that you should also review. This hole is called the Obturator Foramen, which also might be a lab exam question. Again, know how to spell these words. The Obturator Foramen is where different blood vessels and nerves travel through. And that is labeled right there. So Obturator Foramen, greater sciatic notch, ischial spine, those might be lab exam questions. So focus on those. I'm not including all of them, but I'm helping you out a little bit. So go through these bones of the pelvic girdle and all of these structures on the bones as they relate to that lab 2 practicum list. The bony pelvis is divided into a false and true pelvis. I won't ask you guys questions about that, but there's a greater and lesser pelvis. The male and female pelvises exhibit differences. The female pelvis is wider, shallower, and lighter. The pelvic inlet and pelvic outlets are a little bit different. And again, I won't ask you too many questions about that, but you should know the differences between a female and a male pelvis. This differentiates where the true pelvis is, where the false pelvis is. The major differences, so this is a good slide to focus on because there will be a question about this. The female pelvis is adapted for childbearing, so it's lighter, wider, and shallower, provides more room in the true pelvis. And this is a great slide that details the comparisons of the male and female pelvis. The big one is the pubic arch is much wider in the female than in the male. And this is another look, a side view of the female and male pelvis. And again, you should know this well. There will at least be one test question, whether it's lecture or lab, about a female and male pelvis. All right. So the lower limb then carries the entire weight of the erect body standing up. The bones of the lower limb are much thicker and stronger than those of the upper limb because they have to hold all your body weight. And it's divided into 3 segments: the thigh, leg, and foot. The thigh, the region of the lower limb, is between the hip and the knee, and the femur is the single bone of the thigh. The femur is the longest and strongest bone of the body. That's a good test question as well. The ball-shaped head of the femur articulates with the acetabulum. So here's a look at the femur and some of the important structures you should know about the femur: the head of the femur, the neck. Then we have a greater and a lesser trochanter, which are projections off the bone. Should know both of those. The greater trochanter is more lateral, and the lesser trochanter is medial, the same side as the head. And then we have condyles. The medial and lateral condyle will refer to the medial condyle will be on the head side. The lateral condyle will be on the lateral side of the bone. And then there's epicondyles to the femur as well, which are smaller bumps kind of on the sides of the distal end. The patellar surface is where the patella sits. The linea aspera is a raised kind of ridge on the back of the femur, and that's the femur. The patella is a triangular sesamoid bone. It protects the knee. It's embedded in the tendon that secures your quadriceps muscles, and it provides leverage of the thigh muscles across your knee. Then the leg refers to the region of the lower limb between the knee and the ankle. It's composed of the tibia and fibula. The tibia is medial, it's more massive, so it receives a lot more weight of the body from the femur. The fibula is stick-like lateral bone. The fibula is flimsy, so flimsy fibula on the lateral side. And there's also an interosseous membrane that connects the tibia and fibula together. It's a part of connective tissue that keeps them close together. Rotating knee animation. The leg, the tibia, articulates with your femur at the superior end to form the knee joint, and also with the talus bone to form the ankle joint. The talus is one of your tarsal bones. The fibula does not contribute to the knee joint, but it does help stabilize your ankle. So here's a look at the tibia and fibula. Again, tibial tuberosity, some important ones you should focus on. Medial malleolus is the inside ankle bone. Lateral malleolus is the outside ankle bone on the fibula. And a posterior view as well. Here's a look at the tibial tuberosity, and the tibial has lateral and medial condyles as well, which will kind of correspond to where the lateral and medial condyles from the femur will sit on top of it. And here's the posterior view of the tibia. Here's a radiograph of a knee, which is good to see how everything fits together. So here is the tibia, and here is the femur. And you can see here how the fibula does not articulate with that knee joint at all. It just helps stabilize your ankle. The foot then consists of your tarsus, which are the ankle bones, the metatarsus, which are the bones in the sole of your foot, and the phalanges are your toes, the digits. The important functions of your foot: support your body weight, act as a lever to propel your body when walking, and the segmentation makes the foot very pliable and adapted to uneven ground. The tarsus are the ankle bones. There are 7 bones of the ankle. You do need to know all of them. The trochlea of the talus is where the tibia sits. Other tarsals are located here, and you do need to know all of them. The metatarsus consists of 5 small long bones called metatarsals. They are numbered 1 to 5, beginning with the halix, which is the great toe. So pollex is your thumb, and halix is another word for toe. These metatarsals support your body weight. And then you have 14 phalanges and toes, proximal, middle, and distal, but the great toe has only 2 phalanges, just the proximal and distal. So very similar to how the hand is set up. And this is a great view. I wish there was a hand picture like this, but here's your calcaneus, the heel, the talus articulates with your tibia. You should know these medial, intermediate, and cuneiform, lateral cuneiform bones, the metatarsals, and then the phalanges. And another great look, here's the calcaneus, the heel, the talus articulates with your tibia, and a side view of the foot and a lateral view of the foot, the cuboid, and then your cuneiform bones. There are arches of the foot that there's a medial, lateral, transverse arch. The arches are maintained by interlocking shapes, ligaments. The keystone bones of the arches are the talus and the cuboid. And these arches are important for supporting, again, all the body weight. And you can see an X-ray image showing one of the arches. So here are the bones of the lower limb that you can review on your own and a little bit of the markings with them. Disorders of the appendicular skeleton, we can get fractures, hip dysplasia where the head of the femur slips out, or the acetabulum, club foot where the soles of the feet turn inward or medially. Growth of the appendicular skeleton increases height, changes body proportions. Upper and lower body ratio changes with age. At birth, the head and neck are about 1.5 times as long as the lower limbs, but that doesn't stay the case forever. Eventually, the lower limbs will grow faster than the trunk, and the upper-lower body ratio is about 1 to 1 by the age of 10. So here's a look at changes in body proportions throughout life, and that you can see there. There are few changes that occur in the adult skeleton until middle age. And at middle age, the adult skeleton loses mass, osteoporosis, and limb fractures can become more common as the bones become more brittle and lose their density or mass. And that's the end of chapter 8. Come back for chapter 9, and I hope you guys are all doing well. Thank you for listening.